Hello everyone and welcome to our module on ventricles and sinuses. There are four structures in the central nervous system called ventricles, and these contain the cerebrospinal fluid for the brain and spinal cord. There are two of them that are called the lateral ventricles. One's called the third ventricle and one's called the fourth ventricle, and these are continuous with the central canal of the spinal cord. So here's a drawing of the ventricles in the brain, and the two lateral ventricles sort of fan out like butterfly wings into each cerebral cortex, and then CSF from there drains through a structure called the interventricular foramen into the third ventricle. The interventricular foramen is also sometimes called the foramen of Monro. From the third ventricle, it drains through a structure right here called the cerebral aqueduct into the fourth ventricle, and then the fourth ventricle funnels cerebrospinal fluid down into the spinal cord through the central canal. Over here on the left side of the screen is a CAT scan of the brain, and the lateral ventricles are easy to identify. They're those big black structures on either side of the brain that you always see when you look at CAT scans of the human brain. Over here on the right side of the screen are some drawings of the brainstem, and when you look at brainstem anatomy, you also see the ventricular structure. So right here in the midbrain is this little circle, and that's the cerebral aqueduct. Down here in the pons is the fourth ventricle right here, and down here in the medulla is the fourth ventricle right here. So you come across these structures in a lot of different places when you're studying neuroanatomy. So let's talk about cerebrospinal fluid. This is clear, colorless fluid, and it acts as a cushion for the brain. It gives it mechanical protection, it's a shock absorber, it also circulates some nutrients and flushes out waste from the CNS. CSF is produced by cells called ependymal cells of the choroid plexus. There are four choroid plexuses in the ventricles, one in each ventricle, and these are what make the fluid that is the CSF. The CSF gets absorbed by structures called the arachnoid villi, so it's constantly being produced by the ependymal cells and then absorbed by the villi. Once it gets absorbed, it gets drained into the superior sagittal sinus, and from there it goes to the venous system. So ultimately, it all gets back to the venous system with the blood coming from the body. There is something called a choroid plexus cyst, and this is often detected in utero in babies that are growing in the womb, and this can be a very alarming finding for mothers. It's often normal, but it is sometimes associated with chromosome abnormalities, especially trisomy 18, so a lot of mothers have their baby found to have a choroid plexus cyst, and they go through a lot of anxiety trying to determine whether it's just a normal variant or not. It's often a normal variant. So the most important disease process of the ventricles is called hydrocephalus, and that literally means fluid on the brain, and that's what happens when there's too much cerebrospinal fluid and the ventricles get dilated. So look at this image right here. These ventricles are enormous, and that is what the brain looks like in patients who have hydrocephalus. So hydrocephalus is dilation of the ventricles due to accumulation of cerebrospinal fluid, and we break down the causes into two main groups. The first group is so-called communicating hydrocephalus. This means the ventricles of the brain can communicate with each other. There's no obstruction to the flow of CSF. The problem is the CSF is not being absorbed properly, and we'll talk more about that in a minute. In non-communicating hydrocephalus, there's some blockage to flow. The ventricles can't communicate, and this is usually some type of mass lesion blocking the cerebrospinal fluid from leaving one ventricle and getting into another. Let's talk about communicating hydrocephalus first. This is when there's decreased cerebrospinal fluid absorption by the arachnoid villi, and this leads to too much CSF and increased ICP. The complaint that patients with this condition have is headache, and this is why working up headaches is challenging. Most people with headaches have plain old tension headaches or migraine headaches, but some of them may have hydrocephalus, and you have to sort that out. A key sign on physical exam is papilledema, so when you do a fundoscopic exam and look at the optic disc in the back of the eye, you will see papilledema. On a CT scan of the head, the hallmark is dilation of all the ventricles. In non-communicating hydrocephalus, there's obstruction to outflow of one ventricle, so that ventricle gets big, but the others are normal size. If they're all dilated, it suggests communicating hydrocephalus. And the most common reason this happens is somebody who's had meningitis before, and now they have scarring, so they're not absorbing the CSF the way they should. And if it gets really bad, it can cause the brain to herniate, and we talk a little bit more about herniation in the module on intracerebral bleeding. So the classic clinical scenario you should know about is someone who's had prior meningitis, now has an intractable headache. They have papilledema on exam, and they have enlarged ventricles when you do a CT scan. This is a person with communicating hydrocephalus. Non-communicating hydrocephalus, on the other hand, is some kind of structural blockage of CSF flow within the ventricles. It's often congenital, and there are a lot of different etiologies, most of which are rare, but three that are worth knowing, and we'll talk about in this module, are aqueductal stenosis, Chiari malformations, and Dandy-Walker malformations. This can be caused by any mass lesion in the brain or brainstem that obstructs the CSF outflow. These are some special ones we're going to discuss. So aqueductal stenosis is stenosis of the cerebral aqueduct, which you remember is in the midbrain, and it drains the third ventricle to the fourth ventricle. So you have blocked drainage from the third to fourth ventricle. It can be caused by a congenital narrowing. This is an X-linked condition, so you'll see it in boys. It can also be due to inflammation in utero, so certain viruses that cause intrauterine infections can cause the aqueduct to become stenosed. And the presentation will be enlarging head circumference. Remember, babies won't complain of a headache, but you measure their head circumference at all their well baby visits at the doctor's office, and one reason you're doing that is to look for heads that are larger than they should be for the child's age. That suggests hydrocephalus. Chiari malformations are malformations of the cerebellum and brainstem, and the Chiari-2 in particular causes a severe herniation of a significant portion of the cerebellum. So the cerebellum will displace downward like this, and it will obstruct CSF flow and cause hydrocephalus. Chiari-2 malformations are almost always associated with myelomeningocele, which is a form of spina bifida, and this is when the spine and meninges fail to close around the cord, and the cord meninges protrude out of the spine. This is a picture of a baby down here with some type of spina bifida. So babies with Chiari-2 malformations almost always have myelomeningoceles and vice versa, and hydrocephalus is a major cause of morbidity. Before they had surgical procedures to lower the pressure in the brain, most babies with a myelomeningocele died of hydrocephalus. And the obstruction occurs at the fourth ventricle as it flows out to the canal in the spinal cord. A Dandy-Walker malformation is a developmental anomaly of the fourth ventricle, and patients who have this condition get hypoplasia or agenesis of the cerebellar vermis. So this is a congenital condition. It's often detected in utero or right after birth. So those cysts in the fourth ventricle cause hydrocephalus, and what you see on imaging is a humongous fourth ventricle with a very small cerebellum. There are many, many associated conditions that you can read about that it's pretty low yield to know, but you should know that affected children have hydrocephalus, meaning they have a very large head, they have delayed development, and they have motor dysfunction. They're not crawling and walking the way they should. And this is an image of someone with the Dandy-Walker malformation, and it's easy to identify because it's got this enormous posterior fossa with a small cerebellum. Pseudotumor cerebri is also called idiopathic intracranial hypertension. It's basically like high blood pressure of the ventricles. So there's an increase in ICP, which is intracerebral pressure, in the absence of a tumor or any other obvious cause. These patients present with intractable, disabling headaches. They have papilledema, and they can start to lose their vision if the pressure gets too high. A classic and almost diagnostic symptom of pseudotumor cerebri is something called pulsatile tinnitus. These patients will say they can hear rushing water or wind sounds in their ears all the time. And this is believed to be due to the vascular pulsations in the brain being conducted through all that CSF. But regardless of the reason, this pulsatile tinnitus is something that's very high yield to know for this condition. And the classic demographic is a woman of childbearing age who's overweight. So for reasons we don't understand, this is the highest risk group, and that's what it'll be presented to you as in a board question. You diagnose it by doing a spinal tap and measuring the opening pressure, and we talk about this in the module on meningitis. And one of the medical treatments for this is acetazolamide. It's a mild diuretic, but it has good effects in lowering the intracerebral pressure for people with pseudotumor cerebri. Next condition we'll talk about is called normal pressure hydrocephalus, and this is when you get enlarged ventricles on imaging, which will compress the corona radiata. So just to remind you, the corona radiata is this region in this picture over here. It's all the nerve fibers going up and going down from the cerebral cortex. So patients who have this condition get compression of that very important set of nerves by widening of the ventricles. What's curious about this condition is when you do a spinal tap and check their opening pressure, it will be normal. The suspected mechanism is impaired absorption of CSF, and they think people probably have intermittent high pressure in the brain, but it's just not high all the time, and it's hard to detect on spinal tap. But regardless, what makes this different from pseudotumor cerebri is that when you check the opening pressure, it's normal. Nevertheless, they have these very large ventricles when you do neuroimaging. And the classic triad of symptoms is something you should definitely know for your boards. It's urinary incontinence, gait disturbances, and dementia, which people remember as wet, wobbly, and wacky. So if you see a description of this in a board question, they're probably describing normal pressure hydrocephalus. The treatment is to put in a VP shunt. So a VP shunt is a ventriculoperitoneal shunt, and it drains CSF fluid into the abdomen. This is also the treatment for many other forms of hydrocephalus. You should be familiar with hydrocephalus ex vacuo. This is ventricular enlargement that occurs with age as the cortex atrophies. So what's happening is the ventricles aren't really getting larger, but the cortex is getting smaller because the brain is shrinking. So everybody's brain shrinks a little bit after age 60, but if you have one of these conditions like Alzheimer's or Pick's disease or HIV, it can shrink even more than usual. So on imaging, you'll see very big ventricles, but you'll also notice that the sulci, which are the spaces between those tufts of brain, will also be very big. So ventricular increase in size in proportion to the size of the sulci is what diagnoses hydrocephalus ex vacuo. If the sulci of the brain look normal but the ventricles are big, then you're dealing with hydrocephalus, and so that's a very different condition. So for the rest of this module, I'm going to go through the dural sinuses. These are large venous channels found in the dura. That's why they're called dural sinuses. And they drain blood from the cerebral veins, and they also receive CSF from the arachnoid granulations, and they empty into the internal jugular vein, and from there join the venous system of the body. This is a picture from Gray's Anatomy of some of the dural sinuses. There are more than are shown in this picture. This is the sagittal sinus up here along the top. Down here is the lateral and occipital sinuses. The vein of Galen is here in the middle of the screen, and there are many others that you can see in other anatomical drawings. So of all the sinuses, probably the two that are most worth knowing are first the sagittal, because that's the one that receives CSF, so you may be asked about that in a board exam. And then the second one is the cavernous sinus, so let's talk about that now. The cavernous sinus is this really unique area of the skull and brain. It's a large collection of veins on both sides of the head, and it sits between the temporal and sphenoid bones. This is a picture of it up here in the right corner. And it collects blood from the eye and the cortex and drains into the internal jugular vein, just like all the other dural sinuses. What's unique about this area is that there are a lot of different structures inside of it. So cranial nerves 3, 4, and the V1 and V2 branches of cranial nerve 5 and cranial nerve 6 all run inside of here, as well as sympathetic fibers. They're all traveling to the orbit to innervate the eye. In addition, the internal carotid runs through this sinus. So if you get obstruction of this sinus, you can get a very unique syndrome where all of these structures are impacted. And that's called a cavernous sinus syndrome. This is when you have compression of the cavernous sinus by a tumor, a thrombus, or a fistula. One of the ways this can happen is infections of the face, or maybe the nose or the eyes, or even the tonsils or the soft palate can spread to the cavernous sinus. This is called a septic thrombosis, and so you get a collection of bacteria and blood clot that compresses those structures in the cavernous sinus. Another way this can happen is if the carotid artery ruptures. That's rare, but if it does rupture, you get a fistula. This is a very unique place in the body because you have an artery traveling inside a venous structure. So if there's rupture of the carotid artery, you instantly form a fistula as blood spills from the arterial system into the venous system in the body. And that fistula can cause compression of the cavernous sinus structures. The symptoms of a cavernous sinus syndrome are headache, and then something that's very unique are swollen eyes. The eyes can have edema around them and even bulge out of the skull. You get impairment of the ocular motor nerves because they all travel in the cavernous sinus. You get Horner syndrome because there are sympathetic nerves to the eye running through the cavernous sinus syndrome. And then you lose sensation to the areas supplied by the first and second divisions of the trigeminal nerve because V1 and V2 are also in the cavernous sinus. The last thing I'll talk about are AV malformations of the brain. This is when you have an artery to vein connection with no interlying capillary bed, and they will enlarge over time and cause the symptoms just like any other mass in the central nervous system. You should know that the vein of Galen is enlarged in a lot of these. It's one of the dural sinuses, and it can get enlarged in patients who have AV malformations. These often occur in utero, but they're not always detected then, so the people will be born with them and have them until they start to get large in adolescence or adulthood, and then they'll often present with seizures, although sometimes it can also be headaches. And this is a picture of one here. This is a non-contrast CAT scan over here where you can see the AV malformation, but you see it much better over here when intravenous contrast is given to the patient. And that concludes our module on sinuses and ventricles.